Hi, it's Dr. E with themanualtherapist.com. So today we're going to be looking at basically throwing the kitchen sink at the foot and ankle, mainly for ankle problems, as the ankle has been identified in the joint-by-joint approach and even other approaches before that as one of the joints that actually loses mobility, thus usually causing the knee to lose some stability. The easiest way to measure this for dorsiflexion, I was taught by one of our professors at the University of St. Augustine, is to make sure the forefoot is in neutral and then to measure it in supination. So in supination, you should have about 10 degrees for walking and 20 degrees for running. So it's a very easy compensation to pronate and to evert, and it feels like the end feels not only firm, but it looks like he has appropriate range of motion. Come aside. So you can see that with the eversion cheat, he has good range of motion, but forefoot in neutral in supination, he doesn't quite have that range of motion. So we're going to go over several techniques to improve this. You want to flip over on your belly? So one of the fascial patterns in the lower leg is there's usually a ball, oval-shaped restriction around the lateral superior gastroc, and it's one of the first places I go to when there's restrictions in dorsiflexion. So you can just scan this proximal to distal, or distal to proximal, and first work on that with the sharp side. And after you smooth that out, then progress to various smaller and smaller surface areas while maintaining the force. After it smooths out, you should progress the force a little bit just to get deeper. You could also concentrate around the fibular head, as when that is restricted from going anterolateral, that could also limit dorsiflexion, and it's often limited just posterior to it. You could also focus along the bony contours of the tibia, either laterally or medially. Once you find some restrictions, then you again start with the sharp side and then progress to the deeper, to the dull side for depth progression. And then you would do the same thing medially to help improve tissue extensibility of the gastroc and soleus and also muscle play. So if you find any bigger restrictions that you can't quite release with IASTM stripping, you could also pin and then do some active assistive or passive movement or some functional release to that area. Or you can stabilize and actually scoot to the edge so your foot's off the table. You can get them with your thigh in passive dorsiflexion and then take the tissues and bend them medial and laterally for transverse play. And again, this also further separates the tissues from the posterior tibia. Okay, on your back and flip back over. So for IASTM around the talocrural joint, the subtalar joint, so we're checking a little bit better but still limited in dorsiflexion. There's often very superficial restrictions around the anterior talocrural joint, so you can lightly work on that. Not finding too much here. On the subtalar joint, it's helpful to release the superior aspect of the medial and lateral calcaneus, which would then help promote calcaneal inversion, eversion, supination, pronation, and internal and external rotation. So I would release this on a medial side or on the lateral side, and also on the medial side. After several minutes of treatment around here, here, and here, I would remeasure dorsiflexion. You can really lean into that. You can see that that's actually improved just from that short amount of work here and back here. So starting after the tissue work, then you're going to progress to some joint work. The basics, and still a good technique, is talocrural distraction. So you interclasp your hands on the top of the talus. You can oscillate like that. And under subtalar, you're grasping and distracting like that. So you're grasping along the superior calcaneus. I like to actually do them both at the same time, so I'm going to distract the subtalar and the talocrural joint. So the traditional thrust looks like this. Again, I actually, if I can manipulate them both, I will. So take a deep breath in. I'm going to take up all the slack. And exhale and relax. And the traditional talocrural thrust looks like this. Deep breath in. Exhale, relax. So recheck dorsiflexion after that. Much better after that, and that's pretty much back to normal. Okay, now get up into half kneel. You don't have to stop. So half kneel facing me. That leg forward. Facing me. Yeah. And then you're, there you go. So this is a mobilization with movements. I'm going to hold the talus and prevent it from going anteriorly. Because if there's a loss of dorsiflexion, the talus is going to want to glide anteriorly with the tibia as it rolls over it anteriorly. So when I hold it here, it's going to go posteriorly relative to the tibia rolling over it anteriorly. I'm going to hold the distal tibia posteriorly and the anterior talus. So go ahead and just lunge toward me. And this should be, since it's a mulligan technique, should be 100% pain-free. Do this 3 or 4 sets of 10. And then you remeasure. Now, because the tibia, the talus often goes posteriorly, laterally, that would cause the eversion. So if the lateral talus goes posteriorly and not the medial, that would cause the eversion and the pronation. So often to restore dorsiflexion, and this is a progression, if you push the anterior tib tendon out of the way, then you're on the medial talus. I'm going to push that over with a dummy thumb and then hold that. This is actually quite a bit more painful. This is not a mulligan technique. You can go ahead and do the same technique. And again, you can do this in half kneel. You can do it in a lunge. You can do it in a single leg squat. You can do it in a double leg squat. Is that okay? Mm-hmm. So do this again, 2 or 3 sets of 10. Okay, lay on your back. Continue. Okay, for an ankle sprain, if they have a positive sign, either laxity or tenderness with an inversion stress test, if you posteriorly glide the medial malleolus, scoot toward me a little bit. Mulligan hypothesized that this actually, the lateral malleolus actually got subluxed anteriorly, and that's why this is either painful and or testing lax. So if you squeeze the lateral malleolus posterior, so you glide it posterior and then retest actively and passively with overpressure, if it's pain-free, then all of a sudden this is your treatment technique and this is what's indicated. So there wasn't really a sprain or a rupture here, it was only that this was subluxed anteriorly. So you can modify that by going a little bit posterior and superior, or posterior and inferior. You can add a little bit more force, you can add less force. So acutely it may be tender here, and that they may actually kind of go against Mulligan's rules of it should be 100% pain-free, but obviously, on an acute stage this may be tender. I've done this on a few acute ankle sprains, including my own, and I think it really kind of cuts down on the swelling and the rehab afterward. So to maintain that, all I have to do is take a couple pieces of tape, kind of have them hang off, glide it posterior, and then wrap it around kind of in like a semicircular spiral going up posteriorly, and then anchor them perpendicularly on either end. This is mobilization with movement, again, to improve dorsiflexion, as that is the motion that is most limited. So finding the fibular head, you can go ahead and actively dorsiflex. Okay. I can feel it kind of gliding anterior and lateral. However, that may be restricted in the anterior lateral glide. So the first thing you can do is just stabilize the tibia, get on the posterior fibular head. That might be tender due to the fibular nerve, and glide that anterolaterally. But in terms of range of motion or mobilization with movement functionally, I'm going to hold the tibia and then stabilize that and glide it anteriorly as he actively lunges toward me. Make sure that his knee goes over the second toe. Sciatic nerve, tensioner, and assessment. You're going to flex the hip up to where you start to feel some restriction. You're going to adduct and internally rotate. Full knee extension as much as they have. Then straight ankle dorsiflexion. You feel that? Mm-hmm. Okay. So you could oscillate at the ankle for more of a stretch in the calf, although they actually may feel this anywhere all the way up and down their leg. You can oscillate at the knee. If the symptoms were more lateral, to assess the sural nerve, you're going to dorsiflex and invert. For saphenous nerve, you're going to dorsiflex and evert. And for peroneal nerve, you're going to plantar flex and invert. So depending on what kind of pain they have, medial or lateral, whether it was a medial or lateral ankle sprain, a lot of chronic conditions have peripheral nerve entrapments underneath the scar tissue, and those are just different ways that you can actually line up the nerve.